So, good morning. And I think it's good morning for everyone, or maybe good evening for a few. Welcome to this third webinar of the World Burn Week. We've already had the slot A of the same topic done 12 hours back, and now we are in slot B, and we have people from another part of the world uh, who are right now logged in. May I have the next slide, please? Just a reminder to everyone that auto translation is available to you on Zoom. So those of you who need the auto translation from Zoom, I'll give you a few seconds if you want to move it from English speaking language to the language of your choice. And also you can have captions in your language. May I have the next slide, please? Right. So today we are going to be speaking on the topic is preventing post-burn complications, and we have a panel of four speakers who are well known in that field, and they will be engaging with us and letting us know more about the concerned topics. We have with me, I have Dr. Chong CJ. He is from Singapore, and I'd like to speak a few words about him. Dr. CJ is a consultant plastic surgeon at Singapore General Hospital, and he's chief medical officer in Singapore Prison Services. Also, he is concurrently an adjunct associate professor at Duke NUS Medical School and program director of the Sing Health Tissue Banking Program. He is also past president of our Asia Pacific Burn Association and current president for the Association for Burn Injuries in Singapore. I forgot to introduce myself. I'm Vinita Puri. I'm professor and head of the Department of Plastic Surgery at KEM Hospital in Mumbai. Part of the steering committee of the World Burns Week, we have been working very hard to get you this program for this week. I'm also honorary secretary of the ISBI and the immediate past president of the APBA. So I think we can go on to the talks. The first speaker will be Dr. Tanveer Ahmed. Dr. Tanveer is a Bangladesh-trained plastic surgeon and an associate professor of plastic surgery in the 500-bed public teaching hospital, which is the National Institute of Burn and Plastic Surgery in Dhaka, Bangladesh. He is involved in postgraduate teaching and supervising trainees, guiding theses, and he's designed several educational programs. He is also faculty of EMSB and ATLS in Bangladesh. He is also willing to develop sustainable burn awareness program, prevention, infection prevention, and acute care with his 17 years of burn care experience. Welcome, Dr. Tanveer, and we'd like to hear you.
Good morning. Thank you. Thank you, Vinita. Okay. Good morning. Welcome everyone in today's session on preventing post-burn complications. I'll be focusing on burn infections in low resource setting. I'm Dr. Tanveer from Bangladesh. We'll be with you for next few minutes. According to the ISBA guideline, burn hospitals spread infections via three main environmental routes. This is the surface contact, air, and water. That is why burn patients are at significantly increased risk for sepsis. And this sepsis is the most common cause of morbidity and mortality in the burn patients. If you look into this photograph, there is a big burn with face burn and inhalation injury. Dressings are there, but the infection is evident. The environmental control is not there. The patient's caregivers are very close to him, and we can actually prevent any cross-contamination and the infection in this patient. So the incidence of sepsis in burn varies between 8% and 42.5%. Where the optimum facilities are there, the burn infection is less. But the scenario like the previous photograph, in developing countries like in Bangladesh, is very difficult to control the infection. That is why the mortality rate documented between 28 and 65%. In our hospital, it is around 30 to 35%. So making it the leading cause of death in burn patients. So if we are able to control the burn infections, or if we are able to prevent the infections in the burn wounds, then ultimately we'll be able to reduce the burn complications like the morbidity and mortality of the burn patients. We know about the risk factors for burn sepsis. Depth of injury. More the depth, more infection. Presence of the inhalation injury. Indwelling devices like the catheters and the central venous lines. We need to take care of those devices appropriately, or need to change those devices at its appropriate time. But many of times we can do these things. And size of the burns. More burns, more sepsis, and more death. And delayed removal of the burn tissue, that is the early excision. In many of the situations, we can't access the burn wounds at its appropriate time due to the lack of resources, overburden, lack of appropriate dressing materials, and the facilities. So we have to follow this sepsis management pathway, which should be initiated within 1 hour. We have to recognize earlier the infection and then the burn shock or the septic shock, and we should start the resuscitation as soon as possible to stabilize the patient, and then we have to start the empirical antibiotic. But many of the times in our scenario with large number of patients with limited resources and manpower, we are not able to recognize these things earlier and to start the empirical antibiotics, which leads to more burn death. In this scenario, if you see the 500 patient 300 beds, though it is from 2016, but in many of the countries of the world, they are dealing with the burn patients twice or thrice of their capacity. Like this patient, it's really difficult to control the infection and to salvage the patient. We conducted a small research in our hospital to isolate the organism from the swab and the blood culture. In the swab, we found 60% of the samples are positive for the organism, and the blood culture it is around 30%. And from the wound swab, we are able to isolate the two organisms mostly, Pseudomonas and Klebsiella. Pseudomonas is the more, but in the blood culture, we found the Klebsiella and Pseudomonas. They are in equal distribution, but leading the table. And then we tried to find out the sensitivity pattern. Surprisingly, most of our antibiotics are resistant to these organisms. There is the Pseudomonas, Klebsiella, and the Escherichia coli. But the macromolecules are relatively sensitive to this organism. However, the percentage of resistance among those macromolecules are alarming. And why these infections are spreading? We conducted a small survey, quick survey among our healthcare professionals. Interestingly, we found that other than the nurses, the doctors and other healthcare providers having very low compliance with the hand hygiene, that is less than 25%. Nurses are doing slightly better. That is why we have initiated our IPC program, and hopefully we will be able to improve the situation. So what are the challenges in low and middle income countries? That is the high burn incidence rate, lack of inadequate laboratory and microbiology support, weak infection prevention strategy and antimicrobial stewardship program. Resource constraints leads to inappropriate antibiotic supply. and the higher rate of the antibiotic resistance, and inadequate dressings and surgical facilities. So ideal burn care facilities universally actually inherently impossible to get. Actually, those facilities are based on the local needs and strength of the healthcare facilities of the country. So that is why the facilities and opportunities are not equal worldwide, but there is no difference in standards of burn care. So we need to share the experience among the centers worldwide for betterment of the patient and for our experience sharing. Thank you.
Thank you, Dr. Tanveer. This was a wonderful presentation. I would now like, so we will have a panel discussion and Q&A in the end. So I'll go on to the next speaker. We have Dr. Lakshmi Vaz, who will be speaking on pain. She's the director of the Ashirwad Institute for Pain Management and Research, which has facilities which are exclusively dedicated to chronic pain. She was the head of the Department of Anesthesia at Varia Children's Hospital, and she's a pioneer in pediatric regional anesthesia, and she has multiple presentations on neonatal epidural, caudal, and regional anesthesia, as well as difficult airway, because she's also been working with the plastic surgery patients. She worked as a consultant anesthesiologist also at Singapore at the KK Women's and Children's Hospital. She specifically started pain relief work more than 20 years back in 2002. Uh, she is well known in our circles because she developed a very low dose ketamine based analgesic regimen. She will be speaking about it, which is called the KTM, that is ketamine, tramadol, and midazolam, for the National Burn Center in Airoli, which keeps our patients pain free for dressings and in the wards. And this is since 2008. Welcome, Dr. Lakshmi, and I'd like for you to speak.
Good morning, ladies and gentlemen. I must thank Dr. Puri for inviting me to speak in this August gathering. Burns pain is the most intensely painful insult known to the human body, with significant distress and lasting psychological impact. It's a combination of nociceptive, inflammatory, and neuropathic pains, with acute, subacute, and chronic pains daily. And inflammation occurs with every dressing and if there is any infection. And it's acutely neuropathic right from the start because of the burnt nerves. And there is the additional problem of constant itch from healing burns and even after the healing is complete. Tissue injury leads to inflammatory mediator release, which suppress the nociceptor threshold in peripheral nerves. So this is like a software change which occurs within minutes. And peripheral nervous lesions from burnt nerves produce persistent maladaptive plasticity, so which is like a hardware alteration in itself. In third degree burns, there is no local pain, but the neural damage produces changes in the proximal nerves. All these culminate in central sensitization. Adverse sequelae of poor pain control in burns are well known, yet the pain control remains inadequate globally. The issues and solutions are that pain is continuous, so relief also has to be continuous, and intermittent doses are inefficient because of peaks and valleys of pharmacological action. 24/7 constant infusion with dose increases for physiotherapy and dressing have to be allowed for. This pain is moderate to severe, so it requires an anxiolytic potent analgesic. NSAIDs are not really applicable here because the high doses needed can cause kidney damage. Opioids would be effective, but then there are the problems of respiratory depression, nausea, vomiting, gut motility alterations, and the sedation can be confusing in the presence of septicemia. There is also the problem of addiction and opioid-induced hyperalgesia. Physiotherapy is a specific requirement of burns because it has to be, burn areas have to be stretched to minimize contractures, facilitate rehabilitation, and hopefully prevent need for corrective surgeries later. Nutrition is a non-negotiable high priority in burns. The pain stimulus intensity is that of a major surgery, but we want analgesia at full GA levels without the disadvantages like starvation and physiology alterations. And we want a simple and same regime for all the variants of burns pains without any confusions about what to use when. It also has to be safe in the hands of the junior most doctor, nurse, and parent. We developed a good regime in National Burn Center, which has been in operation since 2010. We use paracetamol as an analgesic anti-inflammatory in oral form and daily mandatory neuromodulators in the form of amitriptyline 25 milligrams and pregabalin 75 milligrams. We use topical anesthesia for easy, painless dressing removal. To the saline, which is commonly used, we add 20 ml of 2% lignocaine and 20 ml of 0.5% bupivacaine. And we use half the dose of bupivacaine in children about 2 years. So we also use what is called as the KTM analgesia protocol for dressings, which comprises ketamine, tramadol, and midazolam. This is our regime at National Burn Center for both adults and children. It is the same. It's just that the doses are halved for the children. And this infusion goes on at 2 ml per hour in the wards, and it can be taken up to 4 ml or 6 ml if the patient wants to be turned in bed or whatever. And for dressing, it is raised to much higher levels, 1 to 5 milligram per kg per hour. In the ward, the dose that the patient receives is extremely negligible, but it provides very good analgesia. And for the dressing, there are SOS boluses available as well. At the end of the dressing, the infusion is reduced to baseline level after the first layer is applied. Patients are usually awake, and by the time they are shifted out, and they can be fed within an hour. For skin grafting, where the pain stimulus can be very high, we give regional nerve blocks with posterior and lateral cutaneous nerve blocks. So learning from experiences has been a great privilege for us at Burns Center. We started out with very little resources, and we had the privilege of witnessing greatness from simple people like this lady. Because we had a shortage of infusion pumps, she said, please take my infusion pump and use it for children. At that time, we had a school bus accident with children coming in with a lot of burns. And another lady called me and told me, children are more important than me, madam. Please go and help them. So pain is a terrible lord of mankind than even death itself. And we must all die, but that I can save him from days of torture, that I feel is my great and ever new privilege. Albert Sweezer. And people who work with burns see this on a daily basis. Thank you very much for this privilege.
Thank you, Dr. Lakshmi. I think the work that you have done at the National Burn Center for the burn patients is really amazing. I have a few questions for you in terms of, there are a few questions specifically because your pain relief seems to be really amazing. And I'm hoping that we can also use this in a very low resource settings. And if you have any more hacks for us, it would be great. We'll take that in the panel. So let me now call upon Dr. Yvette. Now we have Dr. Yvette, and she is from Nicaragua. She is working in burns since 1998, starting in Nicaragua in a pediatric burn unit. She's a medical doctor and she was also administration director of the pediatric burn unit and rehabilitation center up to 2016. Since 2021, she has moved to Taiwan and she's an advisor for the Sunshine Social Welfare Foundation. I'm sure many across the world are aware about the Sunshine Social Welfare Foundation. And she contributes her experience in burns, which is accumulated over the years, along with her networking skills and administrative abilities. She has specifically also led her team in the development of a major regional training program, and she has organized over 30 workshops in the Central American professionals, as well as she ran a burn prevention program for the Nicaraguan elementary schools. She's also played an active role in the international burn community through her participation in various committees in the ISBI as well as for the FELAC, that is the Latin American Burn Federation. Presently, she is also honorary joint secretary of the Asia Pacific Burn Association. Welcome, Dr. Yvette, and I'd like for you to speak. Thank you for being
Thank
here.
you. Thank you for the invitation, Dr. Benita. Hi, good day, everyone. Let's go and start.
Good day, everyone. Thank you, Dr. Benita and David, for the opportunity to share with you in the World Burn Week some of the serious problems that we have in low middle income country, the deformity post-burn. We can see the WHO public health prevention pyramid, but today I am going to focus on the tertiary level. This level is the most appropriate point to discuss when we talk about deformity prevention and post-burn patients. At this level, the goal is to reduce the impact of the injury and improve our patient quality of life. At this stage, it is crucial to continue the rehabilitation plan that we initiated during the acute phase. It is well known that deformity prevention after burn involves several key steps. This procedure beginning with the early excision and skin grafting, followed by the rehabilitation that include proper positioning, mobilization and exercise, as well as splinting and compression garment. The location of burn is crucial, as it allows us focus on preventing contraction in critical areas such as neck, hands, and feet. In children, this is even more crucial because they are still growing and improper position can affect their development. We begin deformity prevention on the very first day in the burn unit. At this stage, the patient receives full support from the burn team. Here are some examples of the proper positioning. We can create in hand a large poster showing the correct and incorrect positioning for burn patient. This visual eye will be especially helpful because the therapies are not available 24 hours a day. It will serve as a useful tool for nurses, patients, and caregivers to remember the correct positioning. At the same time, we can place a small whiteboard above each bed to display the specific positioning instruction for each patient. Mobilization and exercise are essential from the very first day too. Whenever possible, assist the patient to sit on the bed first. Then stand as soon as their condition allows, and finally start walking out the bed. Early mobilization plays a key role in preventing contracture and deformities. However, always coordinate with the medical team, doctors and nurses, to confirm the patient condition and readiness before start an exercise program. Splinting is another crucial component that we need to keep in mind. We have the aesthetic splint and the dynamic splint. The splint avoid contractures, reduce the edema, and preserve or increase the range of motion. During the acute phase, we use static splint, and during the rehabilitation in the outpatient, we use both the dynamic and static splint. Obtaining thermoplastic material could be difficult and expensive. If we don't have it, we can use another alternative such as CAS, PVC, or another locally available material. For example, in Costa Rica, the UT Ginapara used PVC to make a splint. The process is described in the Burn Open Journal. In 2022, Ingrid Perry and therapists from all over the world, with the ISBI's helps, published the first edition of the Innovative Solution book, which included this and other creative approaches to the burn care. You can download from the ISBI's website. The compression could be with garment or facial mask. The best way is when we have a local seamstress with previous training in taking measurement, drawing the pattern, and sewing the garment, and finally fitting on the patient. The garment and mask are so helpful in prevent hypertrophic scar. Let's talk about some barriers that the patient and caregiver have when they are in the rehabilitation phase. First, family limitation. Mothers with several children and with many chores to do at home often have struggles to dedicate enough time to help the burn survivor with the routine exercise or place the splint and garment. Second, economic limitation. Although treatment may be provided free of charge, patients and caregivers still need to cover the transportation fee, food, and sometimes lodging. Third, the distance and accessibility. In some cases, the distance to the burn center isn't very far, but the poor accessibility makes it more difficult for them to come back to the burn center for the follow-up visit. And finally, the most of the burn centers are located in large cities, and many patients or caregivers are unfamiliar with navigating urban environments. When the patient is discharged from the burn center and return to their home, many of them come from rural areas or a small town far away from the burn center. As I have already mentioned, the patient have several barriers when they try to return to the follow-up visit in our burn centers. In my experience, we have to use the ABLS as a bridge between the urban center and the rural primary health care centers. This approach has helped us to maintain contact with our patient during the rehabilitation phase and has been effective in preventing contracture and improve the long-term outcomes. Talk about deformity post-burn is a challenge in 7 minutes. However, we must always remember that the prevention of burn deformity is a team effort, including the patient and their families too. We cannot forget the importance of training. For example, in many low-middle-income countries, the therapists don't receive enough training in burn rehabilitation. It's only when they start working in a burn center they discover a whole new world of rehabilitation. That's why I want to share with you the link for burn rehabilitation training that Sunshine provides. You can scan the QR code to access more information about the different courses and learning resources available in English and Spanish. Thank you so much for your attention.
Thank you, Yvette. That was
My
wonderful.
pleasure.
Yeah, thank you.
My
And
pleasure.
you worked in 2 continents, and that's amazing, using your experience in Nicaragua to now be in Taiwan. Thank you.
Yeah.
We now
Thank you,
have
Dr. Benita.
Dr. Aishwarya Raj, and she's a clinical psychologist. She's currently serving as a consultant clinical psychologist in the Department of Burns Reconstructive Plastic Surgery at the All India Institute of Medical Sciences. All of you know it as AIMS at Delhi. She specializes in psychotherapy, psychological assessments, and the management of various psychiatric disorders with a particular focus on trauma, recovery, and resilience. She's also served as a resource person for the Indian Medical Association National Standing Committee on Emotional Health and Emotional Well-being of medical students as well as doctors in India. As we know now, that's something that doctors do need. And it's really great to see that Aishwarya has worked on that too. As well as she's worked on stress management and work life balance at the CBI headquarters. She believes that mental well being is a way of life, and in her free time, she enjoys enhancing her psychotherapeutic skills and is an enthusiastic astrophotographer. I also know that last year, Aishwarya was part of the team and actively involved with a lot of local programs for the World Burns Week at their institute in Ames. So, welcome, Aishwarya, and I'd love to hear your talk.
Thank you so much, ma'am. Let's begin. Everyone, thank you for being here. Thank you, Dr. Vanita, for this opportunity to talk about this very important topic, which is preventing post-burn complications, psychological problem prevention in burn care patients. So when we talk about prevention of complications, we usually mean infection, contracture, deformity. Yet there is another infection, which is of fear, shame, and silence that spreads faster if left unseen. And today I will talk about how early psychological care prevents the invisible complications that shape long-term recovery of these individuals. So first, we need to understand what psychological complications arise and why they occur so universally in burn survivors, so that the how makes sense not as an extra but as an essential. So what can be the psychological complications that can occur in burn patients? It includes acute distress, which is fear, helplessness, flashbacks, mood disorder, depression, hopelessness, guilt, anxiety, leading to hyperarousal or distress related to dressing. There can be panic as well, and body image distress, and associated with social withdrawal, family emotional contagion, including high expressed emotions, which includes blame and guilt, and post-traumatic reactions such as nightmares, avoidance, and emotional numbing. So why do psychological problems occur? So there is neurobiological overload, constant pain, and sensory input leading to amygdala hyperdrive, loss of control, which leads to dependency, and a lot of medical procedures. There is a sense of altered identity in terms of appearance, function, and future plans get disrupted. Also, because of that, there is social isolation, there is stigma, pity, and curiosity by others in knowing what happened, how it happened, and when it happened. There is family anxiety spillover because during such an incident, the emotional ecosystem collapses. Then the major question is, who needs psychological prevention? So any individual who has experienced a burn injury would require psychological intervention. The degree may be very different. Why so? Because it is a life-altering event. There is repeated extreme procedural pain, not a one-off trauma. There is visible disfigurement. There is stigma, gaze, and identity threat. There can be high and persistent PTSD and PTSS burden, which is post-traumatic stress syndrome. This justifies the universal early prevention over a wait for symptoms kind of an approach. Burns create multiple wounds over a period of time. There is a primary burn, then there is a donor side. There can be revision and corrective surgeries, and each stage reopens fear, pain, distress, and grief for any individual experiencing that. Also, there is family emotional climate, which is usually unusually consequential because there is a dependence for feeding, positioning, sometimes dressing tolerance also relies on caregivers for months. There is high expressed emotion, like we just discussed, criticism, over-involvement, and a lot of panic, which strongly shapes the outcomes. Also, what takes a hit is social role and livelihood of these individuals, and sometimes the location of the burn is also impactful, such as face and hands, which affects the recognition, employability, and social participation of the person. So what we have understand the what of it now, when and where to begin prevention. So when do we start the prevention? We start it as soon as possible, and early the better. So at admission, even if it is a 5-minute check-in, that's helpful. During the first week and the following weeks of admission, we have to assess acute stress reaction, the coping style of the patient, how to build the coping style, and how to develop resilience. Post uh, Post that, during pre-discharge time, we do a transition counseling, and we also offer them a coping card, which is tailored according to their coping style and needs. And post-discharge, there is a 1 week tele follow-up, or if they want to walk in, they are most welcome to do that. And there is a monthly review. So the next question is, where do we do it and how do we do it? So at bedside, generally all the individuals are in the ward or non-ambulatory. So a brief 5-minute grounding session, pre-dressing, or just a normal check-in every day is very reassuring to them. In waiting areas, that's the best area to psychoeducate them, give them some information, and answer their queries and questions. Family corners, since individuals who are taking care of the patient require a lot of emotional support as well, so offering a safe space to them for expression and guidance is generally helpful. We can also utilize digital space, including WhatsApp support groups and inspiring survivor videos to instill hope and motivation. So how do we prevent psychological problems? So the most important aspect of this is focusing on the 3 C's, which includes containment, cognitive normalization, and continuity. So containment leads to physiological regulation, which is one of the important aspects of emotion regulation and general healthcare and well-being. So teaching them deep breathing in 4 to 6 cycles before every dressing is helpful. Explaining the procedure step by step before starting is helpful as well. Maintaining a consistent, calm tone of voice also instills hope and reassurance in the individual. Reducing sensory overload, adjusting lighting, minimizing noise, and limiting crowd also helps. For cognitive normalization, psychoeducating the patient to understand what is happening now, what to expect next, is also helpful. And normalizing crying, fear, anger as signs of the nervous system, readapting or regulating it is generally seen as helpful and reassuring to the patient. So in continuity of care, follow up with mental health professionals as suggested, continuing OT and PT regularly, nutrition support for healing and recovery. One primary point of contact is generally helpful for coordination and for check-in with respect to the family and caregivers, and also their psychoeducation. If that continues, is generally helpful. Suppose that now we need to understand another important aspect, which is psychological first care. So as mighty the name sounds, the method is also very mighty. So since we know that burn care is emotionally overwhelming, there is fear, pain, shock, shame, and sometimes all of them can appear at once. And in those moments, even us as clinicians, we may not instantly know what to do. So here is an acronym to get started, and it works with all patients, even caregivers. Even if the patient is in OPD, IPD, ICU, follow up, just remember burn and focus on breathing and being present in the moment, understanding what the needs of the patient are, reassuring them for their needs, and navigate them to the next step, which is what to do next. Another important aspect is the invisible patients, which is generally the family and the caregiver of the burn patient, and particularly the caregiver who is taking care of the patient. So that person and even the caregivers face secondary trauma and burnout, and many experience guilt, helplessness, and emotional exhaustion. So what should be done? Psychological support to caregivers on self-care and boundary setting is very important. Support groups for caregivers is generally helpful, and sometimes, it is interesting to see that caregivers themselves form a group where they talk about what's bothering them, what's going on, how's the treatment progressing. And, that's a sense of community well-being that they develop on their own. And, if we as clinicians, we, merge into that and we give them, bite-sized information about how to take care of themselves, that's, equally beneficial. If distress is high and we recognize, there is a high distress in any of the caregiver, so we screen them and we refer them to appropriate professional. So what do we do at AIMS right now? So we screen for psychological distress in bone units early with respect to the patient. Early intervention with psychological first aid is given. We normalize emotional reactions, educate caregivers and the patient on what to expect if the patient is amiable enough, encourage emotional expression instead of avoidance, train medical staff to offer empathetic communication, and use trauma-focused cognitive behavior therapy and EMDR early on for PTSD. So, preventing postpartum complications is not limited to surgical or wound outcomes. It includes preventing chronic psychological morbidity, functional impairment, and long-term loss of quality of life. Early psychological intervention doesn't just support recovery, it changes recovery. And with this, I would like to thank you for being here and patiently listening to the talk. And we are open for questions.
Thank you, Ishwarya. That was wonderful to see the work that you are doing at AIMS. I think we can now open the panel discussion since we have a lot of queries and there are some also coming in into the question and answers. May I request Dr. CJ to start with
Yep.
the panel questions.
Thank you, Vinita. I think we have Dr. Robayo from Bogota who's asking, I will direct that question to Tanvir, whether traditional medicine, if there's any natural remedy that he has found to be able to control infection. Tanvir, please.
Thank you. Actually, in our country, we didn't try for anything, or according to our regulated boards, we can use any non-pharmaceutical products. However, previously we used the honey in the dressing for some improvement, but in reality, we are not using honey anymore.
Thank you. Perhaps there were some other question is that was previously raised was what do you do for resistant organisms, especially for antibiotic resistance?
Actually, this is the biggest challenge, not only for the developing world, but also for the advanced centers. Actually, there should have a antimicrobial stewardship program or the own antibiogram for the hospital to start with the antibiotics. But in our setting, when we get the resistant organisms in the burn wounds, then we actually bank on the regular dressing chains, the more repeat dressing chains, and then we send the culture for the MIC. So if I get some specific MIC reports, then we try to use to select the appropriate antibiotic in a higher dose. In that way, we are trying to tackle with the infections. But you understand, it's really a difficult situation if all the antibiotics are resistant. In our setting, many of the cases are resistant to all of the organisms. So it's really very tough.
Dr. Tanvir, do you have any local application hacks that you think can help us with control of infection? I understand what you're saying. Many of us face the same issues. Do you have any hacks that you can say, you can use which can help reduce even cross infection, even in a setting which is low resource? If there are any that you all
Yeah.
are using at your place.
Yeah, you understand in the low setting resource setting setups or the countries like Bangladesh, where the number of the beds compared to the number of the patient is really very high. So we can't control the patient attendance or the caregivers to enter into even into the ICU. So in the first outset to reduce the cross contamination among the patients or from the attendants, we start to control the attendance control. That is one thing. Number two, many of the times we have to treat the patients lying on the floor because we don't have enough bed to treat the patients. But we are trying to reduce that thing also. This is the environmental. And three, the awareness I have shown among the doctors or the nurses, the caregivers are also very low. So we are trying to educate them to introduce the at least the alcohol based rubs and changing the dress or specific dress for the caregivers. And number three, surface cleaning of the ICU or the HDU very regularly. In your setting, we use the foam for the beds. You understand? It's never been changed. So you're trying to wrap it up with the Rexins. Thus, no leakage will be there. And number four, we need to change the uh, cotton or oven made curtains or the bed sheets to a more synthetic products. In this, we are actually trying to tackle with this sort of cross contaminations.
Right. I think thanks, Tanvi. These are all good points. We also make sure at our place that the urine pot that the patient uses, those who are not able to go all the way, so we make sure that that is not shared. And also the buckets and mugs which are used by patients for a bath, we try and we also use a lot of acetic acid vinegar for added to the bath water, and some way that seems to control. Uh, Sijat, Dr. Robaya had also asked in that same question, there was also a question probably which Yvette could take. He asked whether if you're aware, know of any options if you're aware for orthotics and splints which are made with materials from rural communities. Yvette?
Yes, in my experience in Nicaragua, for example, when we visit rural area, we found, for example, some people, some therapists, they use cardboard, for example, bamboo, and different material in rural area. But I explained in Costa Rica, we have Dina Parra, she used PVC. It's so cheap, the PVC. The only need you need to know how to use it, and you can find all the information in the open burn. But yes, we can find different kind of material, local material. The most important is remember the basis. What is the proposal for the splinting, the positioning?
Right. So we also at times have used cut IV bottles in the form of splints, especially
Mm,
for the neck. You can very easily, and even for elbow. Regarding
yeah,
PVC, I think you need a heat gun to be able to use PVC. PVC material is the pipes, the water pipes which run outside the building and things like that.
yeah,
Yeah. Thank you, Yvette. Uh,
my pleasure.
yeah. Sijak, you want to take the question, CJ? I think we have
Yes,
a question
I
by
think we
CJ.
do. Yeah, we do have a question for Lechmi, and I think that's from Stephanie Demong. She's probably a fan of your KTM regime, and she asked if we could share that for common usage.
Yes, of course. I'll be very happy if it is used wherever it is used because it was designed for burns patients all over. I'll be happy to share it.
Is it published, Dr. Lakshmi, so that we could share a publication?
You touched a raw nerve, Vinita. We've been just working with it, and Sunil has been after me to publish it. I start writing it, but then, there are so many papers to write, and I'm overwhelmed. But I do realize it is necessary, and I will get to it
Yeah,
soon.
because it is magical the way it works. I have seen Sunil's presentations in our conferences, and I've seen the way KTM is working on the patients. So really, this thing is sorely needed from you. So thank you, and also to let everybody know that these presentations are also going to be available online on YouTube, so you can see them as many times and also pick up the doses from there. We also have a question for you again from Eva, which says that are you worried that the patient may get dependent on IV ketamine?
Unlikely, because ketamine addiction is known when it is used for recreational use, and especially in doses which produce hallucinations. The hallucination dose is somewhere around 3 milligram per kg, whereas what we are using is something very negligible actually. And even at its highest level during the dressing, it does not go beyond 1 to 5 milligram per kg per hour. I'm talking about hallucinations coming in at 3 milligram per kg stat, like an instant injection within 5 seconds. Whereas what we are using is distributed over an hour So it's just not the dose for hallucination, and we haven't seen hallucinations either. And I developed this in children when I'm using regional anesthesia, so that they are just barely asleep, but they are comfortable and they wake up like this after that. So hallucination has not been a problem
Yeah.
Okay.
in doses.
Perhaps a
And also
follow-on
there is
question with
metronidazole. Yes, please.
yeah, sorry. This is I think a very common problem. What can be done for the patients? We've talked about pain, but I think everyone is quite familiar with the itch that comes along.
Yes. See, there are many ways to deal with this. This starting of neuromodulators right from the word go is a very good way to go. Like, you have to start either amitriptyline or pregabalin, because each has its own receptor. But despite that, there is a lot of sensitization which provokes this itch. So when you start your analgesic protocol right from the word go, the neuromodulators like amitriptyline and this one, and ketamine in itself, because of the excellent analgesia, helps in all these things. Incidentally, there are certain acupuncture points which are very useful in itch that also can be used. It's somewhere in the middle of the thigh. But if you have burns in the middle of the thigh, how are you going to do acupuncture there? So that's a difficult thing. But being very particular about pain control and neuromodulation to suppress the sensitization issues will help a lot in suppressing the itch or minimizing it.
Thank you. Perhaps a question to Yvette, not 100% related to her presentation, but it's really regarding how did she manage to implement ABLS in Latin America and the challenges, especially how do you select the particular rural hospital to implement the program? Yvette, please.
Yes. In the 2010, more or less, it was an alliance between ICBIs with Elizabeth Greenfield in that time and Dr. Momet with alliance with ABA, American Burn Association. They make an agreement. They translate the ABLS to Spanish, and after they start the project to train trainers through Latin America. This is one of the ways. So we have the approval from the American Burn Association. The second one is how we select the rural hospital primary. My recommendation that we did is check your data, where the most of the patient coming from. We are talking about rural areas, okay? You're looking for where are the patient, where come from, and then you can make an alliance with that burn unit, the primary unit, and you can help us with the Minister of Health if you have accessibility to them. But the most important is the alliance with the rural primary hospital. You need to find the key person in that hospital, rural hospital.
Yeah, great. So I think we have a wonderful question from Deborah Riley, and this I think Aishwarya will take. This is in the chat. It's not in the Q&A, but that's okay. So she says that mental health caregivers are scarce in the USA also. So how do you actually manage to identify competent people to help with the post-burn psych issue? So you may not actually have a psychologist, but are there any others who could help you with the post-burn psychological issues that you face?
I
Aishwarya?
I think the scarcity is globally present, and we are still training individuals in terms of mental health professionals. Since I also work as the sole psychologist in the department, which is 118 bedded facility, it is a big challenge. So what I have done is I've trained the nurses, right? So they screen individuals for me at times, and then I visit them according to the need and the requirement. Also, a lot of follow up is done through video conferencing and teleconferencing, so that the attrition is taken care of. With respect to creating resources, I think having NGOs and organizations and foundations, including is a big safety mechanism for us. And I think they are the best individuals because they are also in touch with people who are dealing with these kind of issues. So they tend to be very helpful with this.
Yeah, there's one more question for you from Dr. Rabaya, who says, could you offer us a brief guide to psychological first aid for children who have suffered burns?
Right. So I
Very,
think that's it's
very
one of the
interesting
most
question.
challenging.
Yeah.
Yeah, very nice question, and it's one of the most challenging, population, not in terms of that they are pediatrics, but the only language sometimes they would understand is love and hope, right? So first we need to ensure that the children or the child is feeling safe. If they are feeling safe, they will open up with you. They will talk about things with you, right? And initially when we deal with any child having burn complication or post burn injury, and they are in admission, the focus is on containment of fear, then regulating the physiological arousal, and maintaining a sense of safety and control. So a lot of times offering them simple choices, like if they're getting a dressing done, we ask them, where do you want it to happen first? Do you want the face to be cleaned first? Do you want your hand? So that little conversation, that gives them agency, because they are fighting for agency there. They're completely dependent. There is nobody, that they feel close to. Sometimes even the parents are injured. So even the child is worried, and the mother is worried, and the father is worried. So just ensuring, that they are close by, they're, close to each other, they can hear each other, they can meet each other. I think all those things also help. Another thing, that I would say is that we need to encourage expression in children. So it can be, in terms of validating whatever you're feeling is normal. Crying is okay right now. This is the normal reaction. How can we, take it forward? Introducing art therapy modules, also those things help. So I think the first thing would be to ensure safety.
Right. Great. David, no, it's not David, sorry, Aishwarya, I wanted to also ask you, what is the psychological reaction that you think happens in burns patient, which is more often missed? As clinicians, all of us don't always have a psychologist. It's lucky that, Dr. Manish, who heads the AIMS Department of Burns, has you. But so, what do you think is missed more often that you think as surgeons and as other team members we should be aware of, and we can do something about it?
I think it has to be shame, because an individual is in a very vulnerable position, and they have people, clinicians visiting them, taking care of various aspects of their life, and their body, their recovery. And sometimes it comes out as anger and disruptive panic as well, because they don't know how to deal with that. And a lot of times the conversation in their mind is that probably अगर मैंने ये नहीं किया होता तो ये नहीं होता, if I was not there at this time, this wouldn't have happened. So a lot of those kind of questions keep going on, but they get addressed very late. Once the physical recovery is over and they are able to reflect back on their emotions, I think that's when it comes out. And a lot of times there is avoidance also. They don't want to talk about how they feel about themselves, being in that vulnerable position and situation. Particularly in India, the family distress is pretty high. So even the caregivers would ask and comment certain statements which can be very triggering for the patient. So if we take care of those things, I think that's going to be really helpful, and graded exposure over a period of time helps.
Yeah, so Mamta has also written in our internal group, what about psychological support for burn care professionals? So that's true. I just wanted to know, as a lateral from this question or this comment, is that do you think that the psychological support that is provided to the patients by a psychologist, should it be the same person who also handles the burn care professionals, or I should say the relatives, the caregivers also have a lot of psychological issues? So
Yeah.
should it be the same, or do you think that unit should actually have someone else handling these two?
So it's, if it's more, it's merrier. I think that is something that I would say. But since we are talking about building resources and everything, even one person can handle it. And the best way to go about handling caregivers is creating support groups, because a lot of learning and emotional exchange happens when they talk about their own experiences of taking care of their family member. And there is a sense of community well-being, which I have observed has been very helpful. Even caregivers of other patients would rope in and help the patient with, maybe feeding or, doing some other chores around administrative task, some depositing some papers and everything. So they create their own, support system, which is very helpful. And in that, we can introduce simple concepts like it's okay to take rest, and please be mindful of your mood, and just giving them an avenue where they can sit down and relax and maybe watch a movie together. All those things are very helpful.
Thank you so much, Aishwarya. I think we are now, it's time for us to close. May I request CJ to sort of say a few words in kind of like summarize, and then I will close the sessions.
Thanks, Vinita, for organizing this. And I just do a quick summary of what the key speakers have touched on. I think Tanvir highlighted a common problem, which is the control infection. And if you can control infection, you can control complications. He highlighted the problems on the ground, the types of organisms, and what causes sepsis. And he highlighted in his country Klebsiella and Pseudomonas being the key culprits. I think Lashmi has also highlighted a common problem and the KTM process, which is really, really insightful. And she almost shared her long experience of how to get the protocol going to manage pain, particularly in the pediatric community. Yvette shared on the importance of positioning and pre-positioning and the use of simple instruments to do orthotics. And Aishwarya shared on the key parts, the key tenets of psychological care in all 4 phases, including the pre-transitioning and the post-hospital care. These are all very enlightening talks. And as Vinita has mentioned, all this will be available on YouTube, so for you to take a look again.
Thank you, CJ. Yeah, thank you for a wonderful summary of the same. So it's time for us to close this session, but just be aware that we have more webinars which are coming up. The next one will be the day 4 one. I just want to remind everyone that in case you want a certificate of attendance, please do fill out the feedback survey. You could scan this QR code right now, but though it will go off in some time, please don't worry. You will also find the QR code link on the chat, as well as it will come up at the end of the session. There it is. Lisa has put it in the chat. May I have the next slide, please, Lisa? So in the next webinar series, after 12 hours, we will also have the next one, which is preventing the chaos of mass casualties. Please, you could log in either slot A or slot B. Slot A would be 12 hours later, and this same slot will be after 24 hours, where you'll be able to attend the day 4 sessions. You could also, there are a lot of local activities which are happening across the world during the World Burn Week. If you scan this and you also visit our website, you would be able to know more about it. It would be really great if everybody can do their own activities and also get featured, because that is going to really help pump up this across the world, and it will help us learn from each other. May I have the next slide? So thank you to everyone, and also save the date for the next year. Just remember that we do the World Burn Week every year in the first week of November. So we have fixed it as the first week of November. So I hope that this can, be more and more local activities can happen across the world during this week. This is the second one that we are doing, and we look forward to all of you also joining us next year. Thank you once again. Thank you once more to all the panelists also and all the participants. Bye, everyone.
Bye.
Thank you, everyone. Bye.
Bye.
Thank you.